Ventricular septal defects are primarily classified based on their anatomical location within the ventricular septum, the wall separating the heart's right and left lower chambers. Because the septum has a complex 3D structure with membranous and muscular components, different naming conventions exist, such as the Anderson or STS EACTS systems. But they all generally divide VSTs into four main types. Anatomical classification. The anatomical location dictates both the clinical risks like damage to adjacent walls or the conduction system and the approach to closure. Perimembranous VST. Prevalence, the most common type accounting for roughly 75 to 80% of all VSTs. Location, located in the membranous portion of the septum just below the aortic wall and often extending into the adjacent muscular tissue. Because of their proximity to the bundle of His, part of the heart's electrical conduction system, surgical closure carries a slight risk of inducing a heart block. They can partially or fully close spontaneously if the tricuspid wall tissue forms a pouch or aneurysm over the defect. Muscular VST accounts for up to 20% of VSTs, especially common in infants, though many close spontaneously before adulthood. Bordered entirely by the myocardium, that is the heart muscle, in the lower trabeculated part of the septum. Can be further described by their specific location like anterior, midmuscular, apical or posterior. If multiple muscular defects are present, it is often referred to as Swiss cheese septum. Inlet VSD accounts for 5 to 8% of VSTs. Located posterior and inferior to the membranous septum, sitting directly beneath the inlet walls, specifically the septal leaflet of the tricuspid valve. These defects are part of the atrioventricular septal defect spectrum and are frequently seen in patients with Down syndrome. Because they involve the structural crux of the heart, they are rarely close spontaneously. Outlet or supracrystal VST accounts for 5 to 7% of VSTs in Western populations, but is notably more common in Asian populations, up to 30%. Located in the outflow tract of the right ventricle, above the crista supraventricularis, that's a muscular ridge, they sit right below the semilunar walls, pulmonary and aortic, also known as doubly committed subarterial VSTs. Because they are situated immediately below the aortic wall, the lack of support can cause the aortic wall leaflet, usually the right coronary cusp, to prolapse into the defect, leading to aortic regurgitation. Hemodynamic classification. Beyond anatomy, VSTs are also classified by their physiological impact, determined by the size of the defect and the resulting pressure gradient between the ventricles. Restrictive VST is a small defect. The defect resists flow. Significant pressure difference remains between left and right ventricles, usually asymptomatic. Moderately restrictive, medium-sized defect. There is some resistance to flow, but pulmonary pressure is elevated, can lead to left heart volume overload. Unrestrictive, large defect. No resistance to flow, pressures in the left and right ventricles equalize, results in severe pulmonary hypertension and risk of Eisenmenger syndrome if uncorrected.